Good afternoon, everyone. My name is Natasha Gilani, and I am the project manager at the Coalition for Women's Health in Africa. And it is my absolute privilege to welcome you all to our second COA webinar episode. Today, we are here to discuss one of the most critical, far-reaching, and urgent issues facing our continent, family planning. The theme for today is family planning, a catalyst for healthier communities. Family planning is not merely just a set of methods, it is the bedrock of Africa's future. As Africa faces urgent challenges around access, education, and awareness, family planning becomes the catalyst for change, empowering individuals to make decisions that will not only shape their lives, but the destiny of our continent. It's far more important than just birth control. It is the key to unlocking Africa's potential and securing a brighter, more prosperous future for the generations to come. I cannot wait to dive into what promises to be a more powerful and insightful discussion today. But first, let's quickly go over a few guidelines to ensure everything runs smoothly. So this session is being recorded, and we kindly request the consent from all participants. This is for future reference. I would kindly request you all to keep your microphones on mute to avoid any disruption. And we encourage you to share your thoughts and questions in the chat to help us compile them for the Q&A session. Now, I am thrilled to introduce our esteemed speakers and go over today's agenda. We are incredibly fortunate to have some of the most respected experts in the field with us today, who will help us explore the broader impact of family planning and the opportunities it holds for Africa's future. So our moderator for this session is Dr. Nora Maitisa, Country Medical Director for South and Sub-Saharan Africa from Organon. Our keynote speaker is Dr. Eba Seka, Senior Technical Officer for Reproductive Health, Africa CDC. And our distinguished panelists include Professor Anki Hara, President of FIGO, Dr. Stephen Lupeta, Regional Family Planning Specialist, UNFPA, Mrs. Sarah Malaba, Chief Impact Officer from TICO, and Dr. Sheila Masharia, Managing Director for FP 2030, East and Southern Africa. So following the panel discussions, we will open the floor for a dynamic Q&A session. So I please request all of you to submit your questions in the chat throughout the event. And now, without any further delay, it is my honor to introduce Dr. Amit Thakur, Executive Chairman of Africa Health Business, who will set the stage for today's impactful discussion. Over to you, Dr. Amit.
Thank you so much. Let me first give my big appreciation to all the panelists and people that have come from different parts of Africa to join this webinar. And it is really a critical time when we discuss family planning matters. I'm delighted that we have this esteemed panel that will be taking this discussion to the next level. I want to thank all the attendees who've also given us the time for this webinar. On the next slide, I'll tell you a little bit about Coalition for Women's Health in Africa before I give it over to our moderator for this session, Nora Maitisa, who's joining us from South Africa. My name is Amit Thakur. I'm based in Nairobi, together with Natasha. And our team here runs the Secretariat of the Coalition for Women's Health in Africa. A few years ago, many partners came together to discuss about women's health. And this led to forming an independent coalition that is private sector led. It brought like-minded institutions together and started focusing on what we can do in Africa. The first assignment was to decide geographical location. Ghana, Kenya, and South Africa were the three countries that have been selected. The partners that you see at the bottom are members that consistently come to discuss where and how we can improve women's health across the continent. Our vision is an Africa where women and girls have access to equitable healthcare and optimal well-being. This requires us to engage with Africa CDC, WHO Afro, Ministries of Health, and all these wonderful institutions that work tirelessly
Now,
in improving
whether you travel or not doesn't matter. They give you the...
Can we have somebody muting
entitlement, huh?
that?
Huh?
Can we have, Natasha, the mute happening, the controller?
Or
just
is it a
so that we
mandatory
don't
to
have
travel
that?
and then attach boarding pass? It's not.
You can take and stay in there.
Can the host mute? Thank you. I think that was better. So I was mentioning that I believe collaboration is actually the new innovation. And here we are interested in collaborating with many of you and many of the panelists that will be collaborating. I'm delighted that Organon, who is one of the principal founding members, are in the forefront of moving ahead with this coalition. Nora Matisa, who you will hear from just in a while, is from the Organon institution based in South Africa. I want to really appreciate Hologic, BD, Becton Dickinson, AstraZeneca, Abbott, QIAGEN, Jhpiego, Lasix, Siemens Healthineers. I also want to thank MSI, Nigeria Health Watch, TICO, Brands on a Mission, Reach, Pink Drive, Village Reach, and the Cure Cervical Cancer. You can see all the names there. My work is to let you know that this coalition exists for you. It exists for your organization. It exists for your institution. Please feel free to write to us and join us to make a difference in the Coalition for Women's Health. With those few remarks, I'd like to hand it over back to Natasha to take on the webinar start. Thank you.
Thank you very much, Dr. Tucker. I'd now like to hand it to the moderator, Dr. Nora. Over to you.
Good morning, everybody. Good afternoon from different parts of Africa. Very delighted to be a part of this initiative of COHA. We know that in Africa, women and girls' health is still a low on policy and political agenda in our African countries, resulting in alarming health indicators. Somebody needs to please mute. Thank you. And we know the highest maternal mortality happens right here on African soil. This is the reason why the Coalition for Women's Health in Africa was born, following the first Africa Health Business Women's Health Summit held in Nairobi about 2 years ago, where a commitment was made to improve the state of women's health in Africa through private sector and NGO partnerships, which ties in with Organon's purpose to help women, girls achieve their full potential through better health. Organon's vision is to create a better and healthier every day for every woman, and why Organon became the principal founding member of the coalition, together with other private sector organizations, and as AHB being the secretariat, with a hope to create a platform, a unified platform that works towards an Africa where women and girls have access to equitable healthcare and optimal well-being. The mission of COA is what brings us here today, to create dialogue, advocacy, and action towards a better health for her, which we believe will lead to a thriving communities and society. Help me welcome our esteemed panelists and our keynote speaker today, who are all experts in the field of family planning in Africa. We want to encourage dialogue and collaboration among different stakeholders within family planning, highlight grassroots solutions and successes, advocate for greater funding in family planning, and address barriers to family planning and access and the use of contraception, and increase awareness for family planning impact to increase the women's health and societal well-being. Our keynote speaker, a man who needs no introduction, from Africa CDC, Division of Disease Control and Prevention, Eba Seka, who's the Senior Technical Officer, Reproductive Health. He's a trained community health nurse, a registered nurse, and a midwife. Holds a Master of Philosophy degree in International Community Health from the University of Oslo in Norway, with over 24 years experience in public health sector and experience within the UN system, at UNICEF, within the Gambia country office, and WHO. And also has served across all levels of healthcare delivery system within Gambia National Health. Please help me welcome Eba to give us our keynote today.
Thank you very much, moderator, for giving me the accolade. I am very pleased that from the Africa CDC to be affiliated with this very important activity. And it's my pleasure to speak about this very apt, topic, family planning as a catalyst for healthier communities. It is no doubt that it is the healthy communities that forms healthy nations. And when nations are healthy, obviously, the world will be healthy. That's a collective responsibility. And first of all, I just want to serve as a reminder that among the 1.9 billion women of reproductive age, group 15 to 49 worldwide in 2021, 1.1 billion have need for family planning. And of these, the 874 million are using modern contraceptive methods. And 164 million have an unmet need for family planning. So furthermore, between 2000 and 2020, the number of women using a modern contraceptive method increased from 663 million to 851 million. An additional 7 million women are projected to be added by 2030. However, reducing unmet need for family planning has been a central aim for reproductive health policy programmers, researchers over the decades. But despite the progress that we have made over time, it is estimated that over 222 million women in low and middle income countries have unmet need for modern contraception. And ending the unmet need for family planning, according to projections, for 78 priority countries will cost about 41 billion. So that is telling us that it is actually resource intensive and everybody must have to come on board. The global and the national pronouncements in terms of policies often assume that the cause of unmet need for family planning is only limited to inability to access family planning services. And this is certainly not. There are amples of evidence from research on family planning over the decades, not only mention the abundant anecdotes and testimonies from the field, that the obstacles to contraception go beyond access to services alone. There are a plethora of non-access barriers, and which we need to break together. It's a collective responsibility. And these non-access barriers include fear of health side effects. That's why as health workers, it's very important to be giving the right counseling and also giving the effective communications to the people. Let people understand their whole health. Let people take responsibilities of their own health. But the informations need to be clear, credible, and concise for it to be trusted. There are also some normative acceptability that include the religious beliefs, social acceptability, which of course includes partners' decision. In many communities, the men are the gatekeepers, and they take a lead in taking the decision. So it's very important for them to understand the health of the populace and so that they can support women. We have seen instances in actual clinical practice that woman who is underprivileged will deliver up to 8, 9 children, and we have the desire to actually stop delivering again, because we know for certain that uterus expands. The more you deliver, the more you're prone to getting the complications. And it's actually the complications that are killing those mothers. So there is need for us to bring men on board to support women to enhance their own health. Not limited also to the non-access barriers. There are key fundamental things that I want to talk about here, linked to the subject as an intro. One of them is family planning is a human right. We want to also look at the family planning from the public health perspective. We want to also look about family planning from the economic. Importantly, the demographic dividend, which I will dwell on a little bit. Family planning, access to safe voluntary family planning is a human right. Family planning is central to gender equity, women's empowerment, and it is a key factor to reducing poverty. Yet in developing regions, as estimated, around 257 million women who want to avoid pregnancy are not using safe and effective family planning services. Then we have the role it plays in not only making the services available, but the services should be available and also safe to be used. Use of contraception advances the human right of people to determine the number and spacing of children should be a human right. It should be something that, so pregnancy itself should be by choice, but not by chance. Another aspect that we need to consider is the behavioral change services, the beliefs, the misconceptions, the misinformation and the disinformation that we need to definitely control. By doing that, it's our responsibility to educate our communities about all these factors. So making decisions to have a lasting impact on lives is another important thing that will enhance both the health of men, women, and children. Peer pressure is another factor that could be positive, but as well can be very negative, depending on how you handle it. That's why I will be talking more about youth and adolescents in relation to family planning services. Another thing is the economic rationale. The adolescent and youth are the workforce of the population and the parents of tomorrow. So therefore, they need to be protected with the use of family planning services effectively for that matter. The benefit of investing in family, in adolescent and youth, it can be very cost effective if you handle it very carefully. So therefore, getting into the demographic dividend, there are over 1.8 billion adolescents and youth in the world, about 300 million whom live in least developing countries. So therefore, the demographic dividend is the accelerated economic growth that may result from a rapid decline in a country's fertility and subsequent change in the population age structure. So with fewer births, as documented here, a country's working age population grows larger in relation to the young dependent population. With more people in the labor force and fewer young people to support, a country can exploit the window of opportunity for rapid economic growth if the right social and economic investment and policies are made in health, i.e. education, governance, and the economic aspect. While the benefit of the dividend can be great, the gains are neither automatic nor guaranteed. Africa is under enormous pressure to decrease its fertility rate, and access to family planning services is very critical. In many countries of the region, young people constitute approximately 33% of the population. On average, more boys and girls initiate sexual activity during adolescence, whether we like it or not. In some countries of the region, 25 to 27%. of the first birth occur among adolescents. And adolescents contribute to the high maternal mortality in the region, accounting over 40% of the maternal deaths in some countries. Use of contraception prevent pregnancy-related health risks for women, especially for adolescent girls. And when expressed in terms of birth intervals, children born within 2 years of an elderly sibling have 60% increased risk of infant death as elucidated in research. And those born within 2 to 3 years, 10% increases compared to those born after intervals of 3 or 4 years. Furthermore, 20 million unsafe abortions take place a year, of which 95% of these abortions So using the right contraceptives to control that is definitely very, very, very key. But sometimes there are challenges. The challenges could be religious. The challenges could be social. The challenges could be infrastructural. So it was a responsibility for us to come together and control it. And complications of unsafe abortion. At least 78,000 women as documented every year, while thousands of other women experience long and short-term disabilities, severe bleeding, injury, internal organ fatigue. Therefore, pregnancy should be by choice and not by chance. Let alone talking about the sexually transmitted infections that include HIV and AIDS. And each year, 1 out of 20 adolescents get STIs, which could be prevented. Take, for example, the use of the condom. In developing countries, most HIV infections we know are due to sexual transmitted, are translated sexually. So there is a role that we can play. And there is a mechanism that we can collectively engage on to control this. Coming back to the African Union, as I work out of the Africa CDC as a technical arm of the African Union, in 2017, the African Union launched the action towards demographic dividend with the aim of harnessing the demographic dividend through investment in youth. So member state believes investment in youth are important in ensuring African member states take full advantage of the demographic dividend. There are major indispensable elements that should be considered to prepare the demographic dividend. Therefore, investing in the health system. And key among them is increasing family planning programs to decrease fertility, decrease infant mortality, and maintain a healthy childhood and adolescence, which translate into productive adulthood. Investment in quality education. Education is very key, from primary, secondary, tertiary level institutions that produce a responsive and capable workforce must be instituted. Employment opportunities, good governance, raising the gender-based barriers, and leveling the playground in investing in the youth and adolescents is very key. So African countries expected, there are key countries that are doing very well, and they are about even to enter into the demographic dividend. Take, for example, Mauritius, Namibia, Botswana, Kenya, South Africa, Cape Verde, Uganda. Is this telling us that it's the East that is doing best? Something that we will hear along the discussion. A low fertility rate is very important considered for demographic dividend. Data suggests that in most African countries, the demographic dividend is not going to be realized within the next 30 to 50 years. So therefore, we need to ensure multi-sectoral response for positive adolescent and youth development. Support the school health programs and ensure the referral linkages with the youth-friendly services. Support the public health sector to scale up youth-friendly services using various evidence-based modalities. Empower the adolescent and youth to continue to ask about their health. Collaborate with other partners to include age-appropriate, culturally sound, and legally sensitive for that matter, comprehensive sexuality education. Strengthening community engagement and behavioral change communication to increase demand for family planning services and change behavior to increase uptake. Furthermore, there are 3 strategies that have been substantially documented to have contributed to the reduction of maternal mortality. And key among them is the provision of emergency obstetric and newborn care management, skilled birth attendant, and most importantly also, family planning services. Accounted for 69% of the global maternal deaths in 2020. And universal access to sexual and reproductive health care services for sub-Saharan 8%. The major complications which account for almost 75% of all these deaths are severe hemorrhage, infection, high blood pressure during pregnancy, i.e. the pre-eclampsias and the eclampsias, in which family planning services play a critical role in trying to ameliorate all the complications that are related to all these factors that eventually cause the death. Whether we like it or not, the evidence shows us that 15% of pregnancies must end up with complications. And it's the complications that are killing these mothers. So therefore, we should work together to reduce the complications. And compared to 2017 and 2020, the maternal mortality increased in 30 countries. But for us to reduce this standard to the level of what we desire, 70 per 100,000 lives by 2030, we need an annual reduction of at least 20.3%. This is very ambitious, and all hands must have to come in there. With less than 7 years to go to the SDGs, maternal mortality is still very high. Still very high. And we need to come together to bring it down. Furthermore, I will say certainly solving the predicament facing women is a crucial development objective. But sometimes it's a neglected instrument for health. Yet the burden of reproductive ill health in terms of dollars and economic loss is enormous. It's equal to over 20%. So the burden of women related to sexual and reproductive health needs to be ameliorated by coming together to work towards it collectively. The alarming high maternal and child mortality rate in Africa underscore a deep-seated inequality in access to essential healthcare services. And they reflect a broader challenge related to healthcare infrastructure and socio-economic disparities. Every maternal death not only represents a profound personal tragedy, but also disrupts the social fabric of the communities and hampers the progress towards achieving the sustainable development goal. Therefore, I will conclude by saying that family planning is a catalyst to ensuring healthier communities. Pregnancy itself should happen by choice, but not by chance. I thank you very much. Over.
Thank you so much, Ebba, for this insightful talk. And it's clear that we still have the highest unmet need for family planning in Africa, since we are lying in the low Middle East income countries. Family planning is a resource-intensive program requiring various stakeholders to come into play to work towards the reduction in these unmet needs for women in our countries. So we need a collective multi-sectoral approach. That's what we are getting from our keynote speaker, but also highlighting that we need to not forget the men who play a critical role in the access for family planning for women. And this will enhance the access to family planning services for women, and highlighting the fact that family planning is a human right. And also highlighting that we need to leave no one behind, highlighting youth and adolescents, that when we invest in this group of women, it has a ripple effect on, socio-economically. If you invest in education, increase access to contraception, this has positive impact on the health of women. Another thing which I'm getting is that the women who fall pregnant unintended they end up having abortions, many of which are unsafe abortions, which increases maternal mortality, which means that family planning needs to be a human right, as you alluded, and that we need to invest in education of these young and adolescent women in Africa, that they need to be empowered, and also increase community engagement and strengthens those engagement at community level, as I believe those who will change behavior at community level, and increase the skilled workforce for healthcare to eliminate the maternal mortalities that we are seeing. Thank you so much for this. And I'm going to go into the panel to allow them to further unpack family planning, not only as a health matter, but family planning beyond just health. And our first panelist is Professor Anne Kihara, who is currently the president of FIGO, the first one from our continent. She's a senior lecturer at the Department of Obstetrics and Gynecology at the University of Nairobi, where she's worked over 15 years. She is president of the African Federation of Obs and Gynae and the past president of Kenya Obstetrics and Gynecology Society. She's a women's health advocate internationally and even locally, and contributes towards technical assistance in policy and strategy formulation and in guidelines in sexual reproductive health and rights in Africa. So for Dr. Professor N, in light of FIGO's urgent focus on maternal and newborn health crisis in Africa, what are the critical barriers to effective family planning services, such as access to resources, costs? How can we strategically address these challenges to significantly reduce maternal and newborn mortality rates? Additionally, how crucial is the integration of comprehensive postnatal care, including family planning and postnatal contraception, in bridging this critical gap? Over to you, Prof.
Well, thank you, Maitisia. I'm really appreciative of being called to this forum. And I really want to go straight to what are some of the barriers. And I have put it very simply, the rules of P. Family planning, we must plan. If you do not plan, you actually will not succeed. We must prepare ourselves, promote, prevent, and protect. In preparing, we have to take steps in counseling to give informed choice, method mix, decision-making, timing of when the contraception should be given, meet the demands of the community that really we serve. And as my previous speaker spoke, health-seeking behavior. Promote safe motherhood. I mean, family planning is an integral pillar in safe motherhood, which I'll allude further down, that even addresses vulnerable and marginalized populace and child spacing. Prevent unintended pregnancies, because again, these will predispose that woman to unsafe abortions and even mortality. Protect, and I'll repeat this, protect the next generation. And beyond family planning, also articulate other benefits such as breastfeeding as a method of family planning, opportunity to nurture your babies. Some of the complications we do see as gynecologists may be abated by use of family planning, including cancers, endometrial and cervical cancer can be prevented. And family planning is a human right. We cannot get to achieve sustainable development goals if we do not invest in people, in the environment, peace and security, our prosperity, and especially the quality of the next generation. Next slide. On this slide, I'm just articulating the human rights base for family planning. And you can clearly see it doesn't start at the individual. You can look at it from the legal and policy perspective. You can look at it at service delivery. And here I want to belabor particularly to the following: quality of the commodities that we give the patients or clients coming to us. The need for integration, particularly when you look at programs such as the childhood immunization and getting the mothers onto family planning, issues of prevention of mother-to-child transmission of STIs and HIV, lifestyle changes. We've got to integrate family planning to have a healthier community. The total marketing approach. A lot of people think family planning needs to be at the health facilities, but even somebody who's put some comment in Q&A, we are in communities more and more. And we need to also embrace public-private partnership. But again, I do not want to overlook the fact health literacy of communities is critical as a first step. And above all, and now more importantly, self-advocacy, self-determination, self-care. Next, please. The epidemiology has been alluded to us, but I want to focus on the unmet need. 164 million women would wish to delay or avoid a pregnancy. Looking at the Kenyan data as just an example, 2 million women would wish not to have become pregnant, resulting in over 600,000 abortions and 10,000 losses of maternal life. This is senseless death. Is it preventable? Tick, yes. Family planning is the game changer. Next. Next. Next, please. There. Now, I put this slide, stop there for a minute. I put this slide to reflect a lot of things in a nutshell. We want mothers, newborns, children, and adolescents to survive. The question is that pregnancy planned for? And if it is, providing of safe motherhood. But if she doesn't want to be pregnant, then family planning should be put upstream. So pre-conceptual care, interbirthing intervals, you make sure that woman is well family planned so that when she wants to be pregnant, then the policy environment, the guideline environment, the program environment ensures it will be a healthy outcome for both the mother and the baby. On the extreme right, I'm putting what is called obstetric transition. This is Africa's predicament. We have very high total fertility rate. We have very low contraceptive prevalence rate, very high unmet need. Therefore, women are getting pregnant too often, too soon, with the complications that are associated with it. Postpartum hemorrhage, hypertensive disease, hyperglycemia in pregnancy, poor outcomes for mother, poor outcomes for baby. In some cases, they will even seek unsafe abortion. Beyond that, if the baby is born, then we have a problem because we may have very small, vulnerable babies, prematurity or small for gestational age, babies that will cost the health system. Click to the next one, click. So this is where I say family planning and contraception is the game changer. Next. So look at this slide, and I just want to focus on the extreme right. If you have unintended pregnancies, you will actually have the problem of what I have spoken earlier. Put in family planning, 60% of them will have a changed dispensation. Unplanned births, it will provide 63%. Abortions, we will be saving 58%. Maternal deaths, 63%. And it's very clear from research, every dollar you spend on contraception, you make a saving of $3 for the mother, the newborns, and even in abortion care services. So is this really something we should be discussing? This is definitely a return on investment and transforms the lives of the women that actually take it, giving them an opportunity for participation in education, participation in employment, participation in empowerment. Next. We've been told about demographic dividends, but on this slide, I really want to focus on this adolescent girl. A young adolescent who does not family plan, gets sexually active, may end up with child marriage. This is common in Africa. FGM, motherhood. Teenage pregnancy, motherhood. They will leave school. They will end up having recurrent pregnancies, remembering each time she does get pregnant, she's getting a complication risk as a possibility. So as I always tell people, one foot is always in the grave. Our work as the healthcare provider is to keep both of them outside. And you can see very clearly between the green and the red, the interventions the healthcare worker can provide, which include the following: family planning, access to skilled birth attendants, health system strengthening, child health interventions, comprehensive sexual education. Health workers must be also competent, addressing the laws and the policies required, including youth-friendly policies and services. providing for work-life balance and incentives and social safety nets and lifelong learning. This is really what then pushes the development agenda for us remaining in school, our health, and living standards. But more importantly, the next generation is much better off. Next. Unmet need. Look at this slide. Typically in the world, it's about 16%. You come to sub-Saharan Africa and Asia-Oceania region, it's close to 40%. What are some of the reasons? Myths, taboos, misconceptions, strong gatekeepers and influencers that prohibit us discussing family planning. Technologies are not being embraced, and including the mixing of methods of the different family planning methods we now have. Timing. We've talked about upstream family planning. In the postnatal period, we have immediate and interval family planning. Post-abortion, we have family planning. Even with some programs like HIV, and particularly where you have adolescents already infected with HIV, what can you give them as family planning so that the next generation is kept safe? And then poor delivery models that we do have that do not take family planning to the last mile, let alone address vulnerable and marginalized groups. Next. So this is the Kenyan data I alluded to. We can move to the next one. But what is clear on this slide is to show if you are family planning, the health cost to the system is saved $4 every time. I want to speak to the youth. And this is because in Africa, almost 40 to 60% are youthful. But when it comes to teenage pregnancies, we're all crying. In different nations, it ranges from anything from 10% to even up to 50% in some communities. So we must begin to ask ourselves, if they are sexually active, should we not be thinking clearly to have a healthier community and somebody in school so that they can increase their social determinants on a family planning method? Globally, this is what it looks like. 32 million adolescents are in need. 14 million have an unmet need. We must have a rethink, and to be very specific, even put the context into foci. Next. Financing. We can't talk family planning if you don't talk finances. We have issues with financing, and we must speak clearly. What used to be a favorable environment where we had donors that would actually give us a lot of money, now we're having reduced funding and the need to really think as nations on domesticated funding. I've even put on the last slide where you're saying the green is actually the requirement and what we are actually getting. You can see there's a discrepancy. The need is higher than what is actually supplied monetarily. So we must innovate. And I think with COA, this is an opportunity where we can plug in terms of financing for family planning. Next. Looking at the Kenyan situation as just an example, because this is happening across Africa generally, and particularly when you're moving from a low middle income to middle low. We have a planned strategy up to this end of this year where we should be taking the mantle of responsibility much more than the donor community. And this is the reason why we must articulate family planning as a development and for healthier communities and not just medications to women. So co-financing, grants and credit schemes, domestic funding, adjust our normative environment, look at specific budget lines for family planning, invest more in the resilience of a health system, and engage in partnerships. This really must happen. And above all, even conduct research and development. Next. Something we don't talk about, but it's critically important. Climate change is here and it's not going. We have a lot of diseases. We've had COVID, we've had Mpox that is now with us. We've had previously Ebola, we've had chikungunya. These are diseases that are clearly coming up as a result of climate change. More respiratory allergens, the choleras and the diphtherias people are suffering, malnourishment. People are migrating, and we must think of global health security as part of this agenda. Heat-related illnesses and injuries and fatalities associated with mental health and even asthma. But I want to put context a little bit. What's its interrelationship with family planning? Population growth and rapidity of that growth will certainly have an impact on, one, the populace itself in an environment that's becoming more hostile, and particularly for the woman who is pregnant, she has direct effects and indirect effects. And on top of that, we are consuming our natural resources. Our air, our water, our soil is actually getting to be degraded. What kind of nutrition or nutritious foods, what kind of livelihoods are we going to have as a result of this? Carbon emissions are on the high. And let's look at it not just from the local context, but a lot of us are also in the global village. So somebody like myself or Amit, you're constantly in those airwaves. Again, your carbon footprint is a problem. Then, how does this implicate on gender? I want to believe, and coming from a rural populace, my mother knew what we ate, but she also tilled the land. Where is the centrality of the woman? Not just as a family planning consumer, but as somebody who's interested in climate for herself and for her household, and therefore rippling to the nation. Next, please. So in conclusion, just click, click, click. Sexual and reproductive health is an imperative right. We must invest in gender equity, political stability, economic development. Recognize our investment case for family planning and contraception and reduce the unmet need. Provide a resilient health system, and particularly the use of long-acting reversible contraception. Engage, like in Africa, in manufacturing and technologies to develop devices and products. But it's not enough. You must have total marketing and data analytics of the same. Promote multi-program and multi-sector engagement to actually make us have catalyzed, healthier communities. This is what I see as my vision and role for COA. Thank you.
Thank you so much, Professor N, for that and giving us as COA where we need to be focusing, where are the important elements that we need to be considering as we are working towards the betterment of the women's health in this continent. We appreciate that you're already giving us where the need is and where we need to be focusing. And just to what resonates with me was the 5 Ps, to eliminate those barriers that you highlighted: planning, preparing, promoting, preventing unintended pregnancies, and protecting our next generation. Thank you so much for that. But also highlighting the fact that when we invest in family planning, for every dollar, we are saving $3, which gives us a huge return on investment as a continent. Thank you so much. And to go on, in view of time, I'm going to call on to the next panelist, Dr. Stephen Mobeta from UNFPA. He's an obstetrician and gynecologist and a public health specialist with 23 years of experience in the health sector, currently working at UNFPA as a regional family planning specialist for the East and Southern Africa region. He has experience in design, implementation, and evaluation of public health programs, particularly in SRH continuum. He has worked in Zambia health system, the UN system, and internationally in NGOs. And he's also studied global diplomacy and international relations, SRH in humanitarian situations, among others of his accolades. Welcome, Dr. Stephen. For you, Dr. Stephen, what are the broader impact of family planning on developmental outcomes, and how does investing in family planning create that multiplier effect on overall development? And what are some of the disruptive strategies that could be employed to accelerate access to family planning, specifically to achieve SDG Goal 3, targets related to family planning? Over to you.
Thanks all over Africa, and I'm glad to be part of this panel. And actually, after the two speakers have eloquently described family planning, there's very little to add. I'm sure you can see that they have eloquently positioned family planning, not only from what we've always talked about it in terms of the health aspect of the family planning, in terms of the pills, the injections, the condoms that we use, but positioning it as, as a development issue. And I think that is what family planning befits. Family planning is not just the health aspect, it has several dimensions. And I would like to re-echo what the previous speakers have said, that family planning has got several dimensions that we need to always remember. That family planning has a health dimension, like the previous speakers have said, in reducing maternal mortality and child mortality. It has a human rights dimension in terms of promoting, dignity and, empowering the right of the women to self-determination. And family planning also has got, a gender dimension, empowering women, making sure that women, participate in the socio-economic affairs of our countries and the global community. But also to remember that family planning has got a developmental, a perspective. Actually, if you recall all our sustainable development goals, the 17 sustainable development goals, actually you can extrapolate and note that family planning has got an implication to achievement of all the 17 development goals. For the purpose of this conversation, moderator, I would like to highlight some of the key benefits of family planning with regard to achieving our developmental outcomes. And focusing on the Sustainable Development Goals, which we have all subscribed to up to 2030, we often emphasize on the Sustainable Development Goal number 3, which is on good health and well-being, as if it is the only, a Sustainable Development Goal where family planning can have an impact. However, I would like to unpack a few more development goals where family planning has a role. Of course, Sustainable Development Goal number 3 on good health and well-being has got a direct indicator that countries are tracking, and all countries are reporting on the women whose need for family planning has been satisfied with a modern method. Okay, so that is a particular indicator on Sustainable Development Goal number 3. So all countries are reporting on that. There is also the Sustainable Development Goal number 5 on achieving gender equality and women empowerment, where countries are reporting on a specific indicator on the proportion of women whose decision, who make their own, informed decision on sexual relations, including contraceptives. So with regard to the SDG agenda, countries will report on these 2 indicators to demonstrate progress made, with regard to access to family planning. All right, so we can safely say that these 2 sustainable development goals have directly addressed the concept of family planning, which simply means that countries, all the 193 member states of the United Nations, have agreed that we need to integrate family planning as part of our development agenda by agreeing to integrate it in these 2, the sustainable development goals. However, you agree with me that many other sustainable development goals, like the goal number 1 on ending poverty in all its forms everywhere, I think it has been alluded to by the previous speakers that, family planning empowers women, can keep our girl child in school, they can complete their education, be able to have a career, join the workforce, and in fact, even excel within their careers, and also contribute more effectively to the economy because we have kept them in school. But also we have given them chance. Once they're in their career, they have got a chance to space their children they're able to decide to go for further education and be able to contribute to the socio-economic development, and in that way, addressing poverty. In fact, it is said that when you educate a man like me, you are educating an individual, but when you educate a woman, actually, you are educating the whole village, and you are going to address poverty. So family planning directly contributes to SDG number 1 on ending poverty in all its forms. You know, we can talk about SDG number 2 on ending hunger, achieving food security, and improving nutrition. We will realize that family planning has a big role to play on that indicator. The indicator SDG, the SDG number 4 on ensuring inclusive and equitable quality education and promoting lifelong learning opportunities for all. We cannot attain equitable access to quality education if we do not invest in family planning. You know, both at an individual level of a woman remaining in school, like I said, but also at the family level, because an educated woman will translate that, that education to the family and to the children. There will be the girl child will remain in school and the boy child will remain in school, and they will be able to contribute to socio-economic development. SDG number 10 is about addressing inequalities, reducing inequalities. People say that education is an equalizer. Keeping a girl in a rural community in school who did not have a chance to participate in the socio-economic affairs of that particular country or the global community, kept in school, will be able to participate. The inequality that we see in our countries can be addressed by investing in family planning. Once we invest in family planning, we enable somebody to have good nutrition, good education, participate in the global affairs, and be equal to everybody. So we can see that if we were to unpack all the SDGs, all the Sustainable Development Goals can be attained through investment in family planning. Now, when women plan their families, we know that they can plan their lives better, pursue their education, join the workforce, excel in their workforce. But this is at an individual level as a woman. My colleagues have alluded to on the return on investment by investing in family planning. And my previous speaker, my colleague, my fellow speakers have indicated that the healthcare costs are as much as $1 invested in family planning can bring as much as $3 return on investments in terms of cost savings, the healthcare cost savings. However, the Copenhagen Consensus has extrapolated these benefits, the economic benefits of investing in family planning, by looking at other potential savings that you can make. So in terms of cost savings, the direct healthcare savings, yes, $1 to $3. But if you add other aspects, the social sector benefits of investing in family planning, the increased education opportunities that you bring by investing in family planning, and the overall, productivity, national productivity, the Copenhagen Consensus has, estimated that when you invest $1 in family planning, you get $120 return on investment through these other aspects that I have mentioned. So family planning is not just a health issue. Family planning is also a social and economic investment. When you invest in family planning, either as an individual, you will be able to plan your family well. You will be able to look after your children well. Your children will be able to participate in the economic affairs. But as a whole, the country will make savings in terms of healthcare cost savings, but also contribute to their GDP to an extent that the return on investment is $1 to $120, return on investments. We are seeing quite a lot of benefits in family planning, and therefore we need to invest in family planning. So how does UNFPA contribute to this, to the family planning program? We all know that UNFPA is one of the UN agencies, but what is important for this conversation is that UNFPA is the UN agency that is responsible for advancing sexual and reproductive health of the countries that we work in. And therefore, we support countries to advance sexual and reproductive health. And particularly in this context of family planning, we do work with countries to advance their family planning programs. We do it in many ways. Some of the ways that we do, the approaches we do is, number one, high-level policy engagement on family planning. I'm sure we are all aware that this week there is the UN General Assembly that is starting. So this month will be a very heavy month in New York, where our leaders are there having conversations about various global development issues. And as UNFPA, we take opportunity of this to engage with our leaders and position family planning as part of the development agenda. So there are several side events that UNFPA is doing to engage our leaders and position family planning. We also do work with regional economic commissions like the SADC, the East African Community. We do engage at the level of African Union to position family planning as a development agenda. But we also do work on knowledge management, generating evidence on family planning to make sure that we understand how family planning is important to socio-economic development. One critical component of the work that we do as a UNFPA is the work we do in supporting countries with regard to their supply chain management. So we strengthen supply chains. Currently, UNFPA implements a program we refer to as the UNFPA Supplies Partnership. So the UNFPA Supplies Partnership is a partnership of multiple donors that put their resources together to support countries to advance the family planning partnership, the family planning programs, and currently supporting 54 countries globally, 39 of them being in Africa. And through this vehicle, we do support countries with, donated family planning commodities to advance their family planning programs, but also tracking the commodities to the last mile, making sure they are reaching the women that need them through what we refer to as the last mile assurance process. Now, donated commodities cannot remain forever. I think my previous speakers mentioned the need for us to have country ownership of our family planning program. And therefore, as UNFPA, we have started working with countries through what we refer to as compact agreement with countries. So all the countries we have worked with, we have discussed and indicated that donations will not remain forever. Donor resources will disappear one of these days. How can we put the family programs into our own hands? And then through the compact agreements, we have observed countries now investing more in family planning. We have countries, for example, Zambia is a country that we can give an example of where the donor resources was the order of the day. More than 90% of their family planning program was donor funded. Currently, we have seen increased investment in family planning from the country, where they are contributing to contraceptive commodities up to as much as 50% of the contraceptive commodities. We have seen all the countries in the region agreeing and signing compacts with the UNFPA partnership program to advance their family planning programming. When we analyzed the data up to 2023, we have seen significant investment in family planning program. For example, in 2020, countries spent about $10 million of their own domestic resources on family planning. As of 2023, countries have spent as much as $44 million on contraceptives through the advocacy for domestic financing. So this is an example of how countries are taking family planning program in their own hands to, make sure that the sustainability of the family planning program is within our own hands. And therefore, let me take this opportunity to urge all of us who are listening to this conversation that family planning program cannot be left into other people's hands. It should be in our own hands. We need to invest in family planning because the return on investment is already highlighted in our previous conversation. And lastly, when it comes to what are some of the innovations and some of the disruptive, technologies we can implement or that we are supporting already to advance our family planning program on this continent of Africa, but globally as well. So I think the previous speakers mentioned some very, very important components of what we can do in terms of disruptive technologies. One of the critical disruptive technologies is investment in self-care. How do we empower women to put family planning in their own hands through self-care? One important technology that has come, I'm sure we all know about Depo-Provera subcutaneous injection, which can be administered by the women themselves through self-injection. Self-injection of Depo-Provera subcutaneous is an innovation that will enhance self-care and putting the family planning into their own hands. My colleagues mentioned the aspect of postpartum family planning, or post-pregnancy family planning as it is called now, which combines both postpartum family planning and post-abortion family planning, meaning that women who are pregnant, immediately they give birth, they should be offered an opportunity to have a family planning method. In fact, strictly speaking, if we are talking about post-pregnancy family planning, the conversation should start way before the pregnancy comes. How do we integrate family planning in the preconceptual counseling that we offer, if at all we do offer it, so that it's part of the conversation? I am planning to have a child, and after I have the child, I would want to wait before the next child comes. I'm going to space my children. So that conversation begins from there, so that when women are pregnant, they are going for their antenatal, that message is reinforced. And when they give birth, immediately after birth, they will have already chosen a method of their choice, and they will start having that method of their choice postpartum. So advancing postpartum family planning is one of the critical innovations or critical interventions that we can employ for us to achieve our family planning goals. So it's very, very critical. How do we make sure that we do not leave the adolescents and young people behind? Part of the ways we are working as UNFPA is through engagement of adolescents and young people, because we know that the future of our continent or the global community depends on the adolescents and young people. So engaging the adolescents and young people and empowering them through, sexuality education in schools, making sure that they are empowered with knowledge to make their own decisions and be assertive, as they grow up and they remain in school. So investing in adolescents and girls is one very critical component of our family planning programming. And lastly, let us not forget to think about people who may be left behind. How do we reach the people who are left behind, especially bridging the humanitarian and development nexus? We know that many of our countries in this region, this continent, are facing humanitarian situations. How do we reach them? With our family planning program. And therefore, as UNFPA, one of our critical work that we do is integrating family planning in the humanitarian preparedness and response plans. So each country, as you know, does develop, the emergency response preparedness and response plan. We as the UNFPA are working with the countries to integrate family planning in there. And in fact, for those of you that may be aware of what is referred to as a minimum initial service package for reproductive health in humanitarian situations, which is a package of care on reproductive health that a country or a community needs to put in place when responding to humanitarian situations. So if a disaster occurs, the health system is disrupted, what is that a minimum initial service package that you need to put in place? So part of that initial service package now includes family planning, because we know even during emergencies or during disaster, sexual activity still continues. Women still have unplanned pregnancies, which may end up in unsafe abortions. And therefore, integrating family planning in there becomes quite critical. And another aspect that is critical to advancing our family planning program is integration of family planning across, not only within the health sector, where we integrate family planning with other services like immunization program, like HIV, but we should also integrate family planning in other sector plans. How do we integrate family planning as part of the gender, sector? How do we, integrate family planning as a development agenda at national level, so that every sector thinks about family planning as a development agenda? So, moderator, to just end this, I would like to indicate and reiterate my colleagues' earlier indication that family planning is not just a health intervention. We should recall that family planning is a powerful catalyst for broader development outcomes. And please allow me to take this opportunity to thank you for organizing this event, and especially that this event comes just a day before the World Contraceptive Day, which is tomorrow. And therefore, it's a very befitting webinar to discuss family planning as a development issue. Thank you for now.
Thank you, Dr. Mubeta, for that. Thank you for highlighting the work that UNFPA has done in advancing family planning access across the continent. And thank you for highlighting that power of partnership, because without these partnerships, women in Africa would still have unmet needs. And hence, you know, the work that Organon does, and we've pledged as well to prevent 120 million unintended pregnancies. And we're tracking well, I believe, in preventing those. And we do this by, you know, allowing access to LAX implants across the African continent. Thank you so much. And I think you highlighted a very important thing, that countries need to really take ownership to allow sustainability of these successes that you've achieved so far. And I think it's a call to governments to increase funding commitments towards family planning. We need to advocate for domestic funding to further, you know, accelerate the access and the improvement of women's health in this continent. And I thank you that you also touched again, not only on the direct health impact of family planning implementation, but you've raised another element of social, on the social sector, where when we invest in family planning, we are increasing the education opportunities for these women, which also in turn increases the national, you know, productivity, further increasing the socioeconomic returns for a country and contributing positively towards the GDP. Thank you for such an insightful talk. Next, without wasting time, thank you so much, Dr. Mubeta. We're going to be calling upon Mrs. Sarah Malaba. Sarah is the Chief Impact Officer at TICO, a public health expert with over 18 years, extensive experience in policy, health system strengthening, technical assistance, strategic engagements in ministers of health with funders, implementers towards scaling high-impact interventions. She holds a global executive MBA in health management and leadership from the U.S. International University Africa and a master's in public health. Help me welcome Sarah. You can come on camera, Sarah. Sarah works for TICO, and one of the things that was mentioned was financing. And I know TICO has done innovative things when it comes to financing. So TICO has been a powerful advocate for the voiceless, Sarah, and amplifying stories of resilience among adolescents and girls and women in the realm of reproductive health. Given the challenges such as stockouts for family planning commodities in public health facilities, what strategies can health system adopt to improve access and create equity in family planning services across the board, ensuring women's dignity is preserved while promoting method uptake? And I hope you can touch on some of the innovative things that TICO has done to accelerate sexual reproductive health among young youth and adolescents. It is a topic that has been coming out very strongly from all the panelists. Over to you, Sarah.
Thank you. Good morning and good afternoon, everyone on this call. It is my pleasure to speak after the speakers who have gone before me and begin to demonstrate from TICO's experience what service delivery needs to look like to ensure that we reach these unmet family planning requirements, especially focusing on the needs of adolescent girls and young women. So I will speak on three major points. Firstly, starting with the one that Dr. Nora has highlighted around the supply chain. We know that there is no delivery without family planning commodities. So that needs to be our bottom line. And I know when we think about a health system, there are other components of that system, whether it's policy, whether it's human resources for health, whether it is data, and so on and so forth. But really, when you think about delivering for adolescent girls and women in Africa, and indeed in the entire globe, there can be no delivery without the commodities themselves. And then we know that when we have commodities present in facilities or in communities, we are talking about enabling access, enabling continuation, and use and exercise of choice around the options that are available to communities. And so when we think about supply chain, we need to ensure that we achieve these components. Challenges within the supply chain remain, and we must address those, including how we quantify and how we forecast. There's also need to have timely and quality data in order to meet the needs of girls and women. And from our experience at TICO, what we see is that when there is stockouts or when there are funding gaps, and so commodities are fewer and less, women are prioritized and adolescents fall through the cracks. So we need to think differently when it comes to addressing the needs of adolescents in the event that the supply chain is constrained. There might be opportunities to think about how we might ring-fence commodities for adolescent girls and young women. We also need to think about the opportunities around differentiated supply chain and ensuring that we strengthen those. I think there have been questions in the chat, and some of the speakers have alluded to the fact that we insist that delivery needs to happen in the health facility. Is that correct? In the event of self-care, in the advent also of community delivery methodologies. So we need differentiated supply chains that speak to these different modalities of delivery. There have also been mention around integration of supply chain and bundling of the supply chain. I think a good case has been given around integrating family planning and vaccine delivery. I think there could be other mechanisms to be able to ensure further integration of the supply chain and bundling of services and bundling of commodities delivery. Lastly, we need to strengthen the structural flows that we see within the supply chain of family planning commodities, whether this is on the human resource that is required to support on forecasting or to support the push mechanism, whether it is in the ordering, and so on and so forth. So I would like to pivot at this point and just think about some of the fundamental questions that have come through around how do we meet the needs of adolescent girls and young women, and how might we think about financing. And I'll start by saying that we need to put our belief in, or the rhetoric on integration, to practice. We all know that integration works for women and girls when it comes to contraceptive access. But there's a critical question around how to make integration work. And I think, and I believe that at the heart of that question is how to finance for integration. We all talk about, we need to, one practitioner to do more than just one service. We talk about, thinking about client flows within communities or within facilities. But the bigger question is, are we financing for integration? And this is where I will share in a nutshell our experience at TICO with the Adolescent Sexual Reproductive Health Development Impact Bond in Kenya, which is an innovative financing facility that we are utilizing today to ensure an integrated approach to delivery. This integrated adolescent reproductive health development impact bond allows us to integrate both the HIV and modern contraceptive access aspects within the intervention in Kenya to reach girls of 15 to 19-year-old. This was made possible by pulling together a private sector investor who was willing to take the risk and put money to begin the implementation. And then 2 outcome payers, who include the Children Investment Fund Foundation and the UN SDG platform. By pulling these 2 outcome payers, what we are able to achieve is that one part of the outcome payers pays for the contraceptive access interventions, while the other payer pays for the HIV-related interventions that include testing, access to pre-exposure prophylaxis, and antiretroviral therapy. Now, what this has made us to know is that, through this power of this innovative tool, we have been able to pull in private sector to support this effort. These kinds of instruments would allow us to open the fiscal space a little bit, because we know that countries are constrained fiscally speaking, and given the emerging public health emergencies and other reprioritization of public health needs within countries, sometimes, funding for SRH is deprioritized, and we know that it has dwindled. So we need to challenge ourselves to figure out how else to finance for sexual reproductive health. I think one of the speakers talked about the fact that access to family planning products is a resource-intensive endeavor. And so, finances are not going to increase maybe, but we need to bring in new players to finance this. And we need to think about different funding mechanisms to ensure that we sustain access for women and girls. And lastly, I want to also think a little bit about the whole question around how we deliver services and what it would take to deliver to adolescents. We believe at TICO, and I believe in that myself as a public health specialist, that we need to always think about a mixed health systems approach. We need to stop forcing women and forcing girls to only think about access through one type of delivery infrastructure, whether we're talking about clinics or we're talking about the public sector. We need to be able to deliver through both the public and the private sector. And I think that when we do that, we will be able to overcome some of the bigger risks that we are facing at implementation, whether this is supply chain, whether this is human resources, whether this is data. We need to make sure that we can mix those health systems and make them work for women and girls. And Dr. Anne has talked about thinking about a total market approach. We also don't want women to be thought about as one bundled group. There are segments to these women and there are segments to the girls. There will always be a woman and a girl who needs a free service. And there will always be a woman and a girl who might need a part subsidy. And then there's a woman and a girl who can pay fully for the services. We need to think like this to ensure that we address the issue of the unmet need. And when we say statements such as we need to sustain and scale only through the public sector, I think we need to remind ourselves that there is a population, especially adolescent girls and young women, and indeed some women who live under what I call multidimensional poverty. These ones will always be enriched if we continue to silo the approach and if we continue to dictate how and where they need to access these services. For us to reach the last mile, and here I'm talking about adolescents who live in multidimensional poverty, who are mostly uninformed or misinformed and farthest from facilities. We need other models of delivery. We have seen that in the HIV space. We need to take services closest to them. And we need to always ensure a girl-centered and a woman-centered approach, including providing them with self-care options. Thank you very much.
Thank you so much, Sarah, for sharing the innovative funding models that TICO has implemented, especially for the young and adolescent women in this continent. And again, bringing what Professor N highlighted about the total marketing approach, where we need to really think about family planning or healthcare for women outside the context of just a healthcare infrastructure, and start thinking broadly so that we don't leave anyone behind. You highlighted the marginalized women who may not access, the traditional means of when we provide health in the traditional way. We need to innovate and think of how we reach every woman at every point they are, from poverty, etc. So thank you for highlighting the work you have done there to improve on access to contraception and family planning and sexual reproductive health for such marginalized women. And thank you, and I'll take it to our last panelist, and I'll request the participants to please put in their questions in the chat as we will have a look at those at the end of this. Our next panelist, Dr. Sheila Macharia, is a Managing Director, East and Southern Africa Regional Hub at FP 2030. She's a public health expert with extensive experience in the field of adolescent health, family planning, reproductive health, maternal, newborn, and child health. She holds a Master of Public Health and a Fellow in Population and Development from Johns Hopkins University. So, Dr. Sheila, how can we effectively engage African nations to prioritize comprehensive data collection on family planning, ensuring that this data is accurately interpreted and utilized by governments and all partners to foster impactful policies? What does the future of family planning in Africa look like, and how will these data insights shape this evolution? Over to you, Dr. Sheila.
Yes, thank you very much, Dr. Nora, and good morning and good afternoon, everyone. Thank you very much for the opportunity to participate. I'm very conscious that for those of you who are on my side of the equator, it is lunchtime, and you are possibly having your lunch in front of you since you're off video. And I encourage you to do that. I wouldn't want to be the one that stands between you and lunch. I also want to acknowledge my esteemed colleagues this morning who have provided such a wonderful background to what family planning looks like globally and what it looks like in the region. And some of them are sitting in New York as we speak, which is excellent. I told them this morning that they are really committed considering the time that it is there. And then, of course, I want to thank the COA, the coalition, for this chance to participate in this. Let me say as I begin that I work in Nairobi, Kenya, and our office is situated next to a local airport called the Wilson Airport. And at this time, there tends to be a lot of airplanes passing by. So if you hear some background sound, please understand that. I have been introduced very well. It is my privilege to be the Managing Director of the FP 2030 East and Southern Africa Regional Hub. I'll talk a bit about FP 2030 and then move to the questions that I was asked by Dr. Nora. FP 2030 is the second part of a global partnership that started in 2012 as FP 2020. Many of you may have known it. FP 2020 was a partnership of government, development partners, civil society, private sector, and very many other groups that came together in 2012 out of a concern that there wasn't progress in family planning. The British government then hosted a meeting in London that launched this partnership. The idea was to focus on 69 countries, and over the period of 10 years, raise the number of women using family planning services so that there will be an additional 120 million women using family planning or contraception. So these would be new users. At the end of the time, it was noted that only half of that goal had been reached, but great progress had been seen across countries. Very many countries had seen their rate of family planning increase. They had seen increased attention to myths and misconceptions. They had seen a lot of work in health system strengthening. They had seen an increase in financing. We then come to the end of that period, and many partners around the world were asked, since we didn't achieve our goals, what should we do next? And the resounding response was that this partnership needed to be decentralized to a regional model that would have people who work nearer the countries so that their relationships are based on the context in the countries, and maybe that we'd see a greater movement. Hence FP 2030, which is the only global partnership that is solely devoted to family planning. At FP 2030, we believe that every woman everywhere and every family has the right to decide if and when to have children, and that means access to information and services, and therefore to participate not only in their own development, but in that of the country. As a result of that, we work towards global reproductive choice, autonomy, gender equality, and with a great attention to adolescents and youth. FP 2030 has 5 regional hubs located in the US, in Asia, in Latin America, and in Africa, we have 2 hubs. I head the East Africa hub. We operate under a strategy which has 6 pillars, and these pillars speak to advancing the recognition of family planning, sustainable financing, prioritizing the rights of adolescents and youth and other marginalized communities, and supporting the scale-up of evidence-based practices. So let me go directly to the question that Dr. Nora asked about data. In FP 2030, the East and Southern Africa Regional Hub, which started in October 2022, we were given oversight for 23 countries. And what we do is that we work with countries to form a commitment. This commitment, called the FP 2030 commitment, is a summary of the country's own national priorities, and it is based on what they have committed to either under Agenda 2063 or the SDGs or their own national goals. So what countries do is that they take all the policies and strategies that they have that address family planning. It can be the national plan, the sexual reproductive health plan, the adolescent and youth plan, and then they summarize all the efforts pertaining to family planning in one document that is called the FP 2030 commitment. One thing that we have found in the 11 countries that have a commitment, that there are common themes that countries are trying to address. They are trying to increase the financing, domestic resource mobilization. They are paying attention to adolescents and youth, cognizant that they need to set up youth-sensitive services. They are paying attention to scale up of high impact practices. They are also, many of them, talking about providing services in emergency situations as part of response. This family planning commitment, then, where do we come in? So when we begin our engagement with countries, we encourage them then to develop a costed action plan or costed implementation plan to accompany that commitment. What that does is that it summarizes the strategies that they want to do, and then it coalesces the partners around that so that they're able to specifically say, these partners, development partners, implementing partners, CSOs, are supporting this part and this part and this part. And government, of course, is supporting everything across that. It's an opportunity for a country to align its partners, to bring in private sector, to bring in the faith sector, to look at, are we duplicating efforts? And then, as FP 2030, once we have seen that in place, and we will finance the meeting, we will work with in-country partners. We'll say that, all right, you want to do this in 5 days, maybe we can, pay for the cost of the conference center, and other partners have come in and paid different things, or we pay for the facilitators, but basically we work to see there's an action plan. One thing that we've been very big about is data. Why? Because we want the country to monitor its commitment. We have said many countries use qualitative data. So partners report, oh, we're doing this in 3 districts. Oh, we're doing this in 5 districts. But that's so general. What about the numbers? So what we have seen as we have visited countries and met with the ministers of health and heads of UNFPA, heads of USAID, heads of the Global Financing Facility, Gates and all the donors, and then the NGOs and various partners, we have seen that the Ministry of Health in its District Health Information System, the DHIS, or the Health Management Information System, often has a dashboard that allows them to identify the indicators where they will collect information from the districts, summarize them at the national level. And then what we have said is that we have in each country an oversight committee for this commitment. It is led by government. It might be Ministry of Health, Ministry of Planning. The development partners are represented, and there's a CSO representative, and a youth-led organization there's a youth representative. What we tell them to do is then, within your FPTWG or your SRH, every quarter, can you meet? Look at your commitment. Look at the action plan. Look at who are supposed to do what. Then, number 2, your dashboard. So we work with them and we ask them, who is the best placed person in your government to summarize the data, because it's, government-led. So they bring in somebody from HMIS. We then have sat down with them in various countries as we visited, Ethiopia, Rwanda, Malawi, and Namibia, so many countries, Mozambique, Angola. And we've said, can you be coming during the TWG and present the summary of these indicators, which is your dashboard, so we're not imposing. We come in very respectfully. We know that you already have a plan. What we are trying to do is to get that done regularly. Can you look at it quarterly, so that by the end of the year, you can actually generate a report that says, this is where we've reached, qualitative but quantitative. Rwanda and Uganda are excellent at doing this. And other countries are also growing. Ethiopia is growing and Malawi is growing. Then we've talked about partner alignment. We come to the table and say we are joining partners. So we want to align with whatever's happening. And in the process of discussion, sometimes we might find that there's a technical gap. So for instance, Tanzania wanted help to develop a monitoring plan for that action plan. And we spoke to a couple of partners, and Gender Health, Marie Stopes, they said they would help. So we also align partners. Then we are very focused on accountability. So the accountability must also go to the sub-regional. So how are we doing that? Many of you have said that district information is collected, but it's not necessarily acted on. I think that's what many partners have talked about. And so what we are saying is that we need to have a place where there is some accountability to the resources that were brought into the services. And so we have given some small grants in some countries to CSOs so that they can do social accountability at the sub-regional level. And we want to see how that rolls out. Now, one big area is sustainable financing. Many countries have a budget for reproductive health, but it's difficult for them to see what is family planning. Kenya has a family planning budget line item. So does Uganda. So does Ethiopia. There are countries that don't exactly have that. And so what we are doing around sustainable financing is that we're not only joining the country advocacy for that as part of DRM, we're raising it at the regional level when we attend meetings like EXA or the network of parliamentarians, so that we amplify it. But at the country level, with some countries, we're even helping them to do a fiscal space analysis that says, let's look at your Ministry of Health. If you don't already have an FP budget, is there a place where there's a saving? Because the Ministry of Health budget is finite. It's a competitive process, but sometimes you find, like Kenya did, that there is some place where there are resources that can then go towards family planning. And the one thing that needs to be funded a lot are commodities. The second is to finance youth-sensitive services. What do I mean? Sometimes to offer good youth-sensitive services, you need a differentiated model of care, one that steps out of the facilities. Or within the facilities, you need a place that is very conducive. That costs, and it needs to be part of the budget. Now, let me quickly move to the question about what does family planning look like and how do we reignite? We have invested heavily in youth leadership. We believe very much that youth should be the ones to speak about their issues. And therefore, when we started the hub, we took the youth focal points. Remember, I told you there's a caretaker committee in every country. So in the 11 countries, we took the youth focal point, who often comes from a youth-led organization, and we brought them together. One is to attend regional and global gatherings where they make presentations about what is being achieved for youth and adolescents in their countries and where the gaps are. We quickly recognized that they needed capacity building in what? In leadership, in communicating, in understanding policy, in data, translating the data that comes out of their countries so that when they're presenting their issues, they are succinct, they can speak to policymakers and at the regional level. We provide a little stipend so that in their country, one of the things we have helped each one of them to do in 11 countries is to develop an advocacy agenda. They are then supposed to come back to the country, meet with other youth-led organizations, and together amplify the message. So for instance, it might be that in a particular country, the gap for them is that there's no attention to youth-sensitive services. Or it might be like in Namibia, young people want to use long-acting methods, but they're not getting access to that. And therefore, we then are supporting these youth focal points to use the platforms that they have in the country to amplify the voices for what are the gaps in adolescent and youth SRH. Teen pregnancy is a big one. Child marriage is something else that they talk about. As FP 2030, let me come to an end with my remarks. Where do we see family planning going? In this third year, what we have learned from the region is that the reality, and has been mentioned, is that resources for family planning from development partners are dwindling, not because they don't care, but because there are other issues that have come in. So one of the things we have established is a Center of Excellence for Emergency Preparedness and Response. We are saying, as many of my esteemed speakers have said, that family planning needs to be integrated into emergency responses, into humanitarian sectors, and all the efforts that are going on in climate, because in COVID, we noticed that fell. The second is sustainable financing. Financing for health depends very much on how countries are collecting taxes. And secondly, we know that African countries have a lot of debt. We have debt from the Chinese government. We have debt because of infrastructure. And therefore, within that, how do we ensure that as the universal health coverage is rolled out and primary healthcare models are rolled out, that family planning services are included in the beneficiary package so that it ends up being financed? Because unless it's included in those universal health coverage packages, what happens is that money goes into reproductive health, covers maternal newborn health, and family planning is left out. We also see that countries need to accept the fact that in 50 years, the youth in sub-Saharan Africa will form the majority of the youth of the world. And that is why we are putting youth at the front, leadership, services for them, being sensitive, the gender equality issues, all the myths and misconceptions. We cannot bury our heads in the sand when there's teen pregnancy and say that young people should not have sex. They are having sex. It's the reality. I am a mother. I say, I would wish that my children would not have sex before marriage. But the reality is that with this gadget that is called the mobile phone, they have so much information from when they're 8 years old. Children are experimenting. It is a reality. So we need age-appropriate information. We don't have to use the word comprehensive sexuality. We can use age-appropriate information. And then we need to provide access to services. When a teen girl gets pregnant, the boy needs to understand that there's a menstrual cycle. And there are days when if you have sex, this girl will get pregnant and you need to be involved in that care. So it's not only the girl's life that's affected, yours is. Policymakers, we need to allow that the young girl gets back to school, but that we face the reality, if she's going to have sex, can she have access to contraception? It's difficult. I speak as a mother. Finally, I'll say this. Family planning has been talked about as being so central to development. In FP 2030, we want to normalize family planning. We don't want it to be a discussion. We want it to be an of course. So as health systems are being strengthened, we want to speak to the fact that make sure that family planning is included. When you're looking at your task shifting, are you looking at family planning there? When you're looking at climate and preparedness, is family planning somewhere there? If you're looking at your information system, is family planning there? Education sector, gender, youth, all of those. So we are actually working with countries to have interministerial meetings and collaborations. And of course, now at UNGA, wonderfully yesterday, we had a session where FP 2030 partnered with UNFPA, and the topic of the day was to invest in the future, investing in the future. And out of this session in UNGA, $300 million has been mobilized. We don't know where it will go or how it will go, but we are so happy that our partnership with UNFPA has brought that on board. So coalition of the COA coalition, thank you so much for this opportunity to talk about this. We need private sector in there. In this universal health coverage, private sector is such a heavy part of it, but sometimes they're just kind of left out there. The information that and their investment in health, sometimes not captured in the health information system. How do we get that to happen? And I know that, private sector is about bottom line. They're not about corporate social responsibility. But at the same time, given all things that the world is focusing on, climate and etc., where can private sector come in? Even the commodities. Thank you so much that you do provide this. Can you see that commodity supply chains continue because you are effectively giving a good price, you know, that country governments can afford. So thank you very much. Let me end there and give it back to Dr. Nora. Thank you.
Thank you so much, Dr. Sheila. And the take home for me is that family planning needs to be on the agenda table on all policy tables across different ministries, be it education, climate change, whatever the discussion is, family planning needs to be roped in. We have run out of our time, unfortunately. And I would just like to perhaps ask Dr. Sheila for parting remarks, because we have run out of time. Maybe Dr. Sheila, maybe just a few words, definitely. Parting remarks, yeah.
Okay, my parting remarks. One is that many of the countries that are represented here by the people who are attending, Kenya, Gambia, so many countries fall within the ambit of FP 2030. And I've noticed some questions about FP 2030. Yes, your governments have made commitments, and COA can give you access to my email address. We can share the commitments your countries have made. What can I say? Let me say this. Let's all work together to normalize family planning. You've heard Professor Beatrice, you've heard Dr. Mupeta, you've heard Sarah, my friend. Let's normalize family planning. Let it not be a discussion. I know that there are faith leaders we need to speak to. Let's do that. I know that there are cultural leaders. Let's do that. I recognize that politicians have to be careful. In a year when you're going into elections, you need to be careful when you're speaking about family planning, because people will be telling you, but we need to increase the numbers of people. If that's the case, then maybe when we're having that discussion that year, let's come in with a lens of respectful care for mothers, care for teen pregnancies. We don't have to come in with something that is controversial, that upsets people. Yes, sexual reproductive health and rights, very important. If the word rights is going to offend, let's find a way so that we get a place at the table. And when we have a place at the table, we can speak to policymakers, because they mean well, but they are handling many things. And this is something that we've come to realize. But let me repeat again, let's normalize family planning so that in the future, it's not a discussion. Thank you very much.
Thank you so much. And I have two questions, and I'm going to give them to Professor Anne Kihara, and they're related to the religious beliefs in some of the African countries in the context of family planning. How, as a practitioner, how do you deal with such cases where the religious beliefs in that country or that particular woman are not aligned to family planning? But also, how do we create adolescent and youth-friendly services at hospital level?
Thank you very much, Nora. You've put me on the spot, huh? Now, I know the sensitivity of religion, and I also know the sensitivity around the adolescent and youth and family planning. I think the first thing I will say is you must be culturally, religiously sensitive. You cannot go and impose your own thinking on others, but to first and foremost gain an understanding of their context, so that one, you're not going to be offensive. Number two is to really give a narrative. And I have really noticed the value of data, because data does not lie. So once you get the evidence to speak, particularly from a given environment, then you find people are more accepting, because you're actually telling them, this is your community and this is what is happening. Then you're able to break the ice, so to speak, to then actually give the value of family planning and contraception. I would say that in a nutshell.
Thank you so much, Prof. And I think there's a question for Dr. Stephen, which I believe he answered in the context of SDGs, particularly Goal 3, which focuses on ensuring healthy lives and promoting well-being for all. How do you see family planning as a critical component in achieving these targets?
All right, thank you so much, moderator. And I think looks like you just caught me typing. I was just about to type the response for that, but let me now take an opportunity and respond to it directly, since I have the mic. I think one thing I mentioned earlier on was that with regard to the SDGs, family planning can help us achieve almost all the SDGs. But with regard to the question that has been particularly asked, family planning, the SDG 3 is one of the SDGs where family planning is directly mentioned. So all the countries have been mandated to measure the proportion of women who are accessing family planning and the proportion of women who are failing to access family planning, what they want to use, but they are unable to use it for various reasons, which we commonly refer to as unmet need for family planning. When you combine those two indicators, you have what is referred to as the total demand for family planning, the total number of women who need family planning. Now, out of that, we want to see which proportion of these women have their needs satisfied with family planning with a modern method. So family planning indicator SDG indicator 3.7.1 is particularly on the need for countries to report on this indicator on the percentage of women who are satisfied with a modern method. However, if we look at the other indicators on maternal mortality, reduction of maternal mortality, some studies have shown actually up to as much as 30% maternal mortality can be reduced by investing in family planning. So by investing in family planning, we can directly contribute to reduction of maternal mortality, which is an important indicator under that goal number 3. If we look at the aspect of reducing adolescent birth rate, which is another indicator on the SDG 3, family planning plays a big role in preventing unplanned pregnancies amongst the adolescents and keeping them in school. So that is quite critical. Indicator 3.8.1 is about universal health coverage. Now, meaning that everyone, everywhere has access to health without, suffering financial catastrophes. Now, if we do not provide family planning service, we are actually missing out on making everybody everywhere having access to services. So family planning is an integral part of SDG 3 and an integral part of achieving universal health coverage with regard to the SDG indicators. So let me end for now here, just to conclude that family planning is very critical to attaining SDG 3. Thank you.
Thank you, Dr. Mubeta. And I'll stop it at that because we've run out of time. We left with only 5 minutes to the end of our session. Let me take this time to thank once more our great panelists and our keynote speaker for taking the time today to be with us as we are on the eve of celebrating the World Contraception Day. This conversation could not have been, appropriate. And let me again thank the Coalition for entrusting me with this panel of esteemed speakers. Let me take it over to Dr. Ami just to give a few announcements before we close.
I think I'm going to step in for Dr. Amit now. I'd just like to thank you all for being part of today's impactful session on family planning and its crucial role in shaping Africa's future. We are deeply grateful to our speakers for the invaluable insights, which have reminded us that today's conversation is just the beginning. The journey ahead requires collective action, collaboration, and sustained efforts, and we are to bring about meaningful change in family planning and secure a brighter future for Africa. So let's continue this important work together. As we close, here are some exciting upcoming COA events. We will be having our inaugural annual general meeting and networking event in October, followed by the 3rd episode of our webinar series on November 13th, which will focus on cancer. We will be sharing details a bit later. And the Africa Health Business Symposium taking place in Nigeria on June 26 to 27, 2025, under the theme Leveraging Innovation to Advance Universal Health Coverage in Africa. Additionally, we will be launching our Sexual and Reproductive Health Report tomorrow, September 26th, in alignment with World Contraception Day. And for more information and to be among the first to receive the report, kindly scan the QR code that's currently displayed on your screen. And at this point, I'd just like to say thank you to all the participants for being so engaging, and to the moderator, Nora, you've done a fantastic job. We had an expert panel of today to speak about family planning. So I'd just like to thank you for taking the time to be here with us, and hope to see you all next time in our next webinar.
Thank you so much.
Thank you, everyone.
Thank you, everybody.
Thank you very much. Bye.
Thank you.
Bye.